Section of, I'm going to show you some more information, more in-depth information about ACEs and their long-term effects, as well as, and then we'll have a part for discussion. But like I said, during the slide segment, please interrupt, and you don't have to raise your hand, just ask a question. And I want to make sure that questions are answered. So I couldn't have framed it what today is about better than what Ben just did, about connecting this science, this literature that's been out there. It informs a lot of our head knowledge, but really the change is in here. And as a believer, as a Christian, the parallels between what this is about and the gospel were so evident. And it's funny because whenever I talk to Christians about this topic, they get it right away. Believers get it. They know, they understand brokenness, and they understand what it can, the effects that our brokenness individually, our broken families, communities, etc., can leave, the kind of imprint it can leave on us. So Christians get it. But this is the first formal, workshop that I've given in front of a church community. I've done this talk, iterations of this talk at grand rounds. Actually, our church, we've talked about it. We have a group that we kind of regularly meet and talk about this. But most of the circles that I present this information to are very academic and science-based. And I've had a yearning to kind of get into the church. And so I'm really thankful for the pastoral staff here for being very forward-thinking. And because this information is going to challenge, it could agitate, it's going to unsettle you to some extent, and it should. And it's my hope and prayer that through that unsettling, then we can move forward in action and have some paradigm shifts in our mind. So again, I'm Stan Sonu. I work at Cook County in a fellowship in preventive medicine and public health. I'm about 7 years past medical school, and I grew up in Atlanta, in the suburbs there. My wife and I consider ourselves transplants to Chicago, and so we think we're going to stay long term. And then I brought with me a colleague and friend, Arya Choi. We attend the same church together. We're at 9th Hour Covenant Church. We meet downtown, or in the city, in the west side. Arya has a social work background, and so she's here to sort of help facilitate when we break out to our discussion groups. All right, so ACEs, average childhood experiences. There's some stuff that's going to overlap with what that kind of 7-minute power talk that I gave back when I came with Scott, Griesiak, and Griff. But a lot of this is hopefully me. So can I get a show of hands? Before I came in June with Scott, who here had heard of this topic? 1, 2. Okay. So it's new for everybody. That's great. Who here works in some sort of medical counseling background? Medical, dentist, 2. Who here is a teacher? Engineers? Okay. IT, I know there. Okay. Any other human service agency that people work at here? Anything? Okay. Any students? Okay. All right. Just to get a sense of it. All right. So the first time I heard this topic, my jaw was on the ground. And when I was reflecting on why I was so shocked, there were really 3 sort of big reasons why this topic kind of wrecked me in a sense. The first one is this. I was in my 4th year, so my specialty is internal medicine and pediatrics, so I see both adults and children. My residency was 4 years long, and it was, 3 months before I was graduating residency, only 3 months left in my 4th year, my last year, when I first heard about this topic. And it upset me, it still upsets me that I did not learn this in medical school. Because as I hope I make clear to you, I hope I can argue this should be fundamental to anybody who works with people not just healthcare, but any social service agency, certainly law enforcement, our justice system, and the faith community. So anybody who works with humans should know this science and this background. A lot of what this topic did for me was sort of represent what I kind of called and labeled the elephant in the room. And I think it's kind of when you step back and think about what doctors do, and I see a patient in clinic, 15, 20 minutes, I get a little bit of their history, and then I have the nerve to tell them what to do with their lives. I have the audacity to say you should do this because of this. And when you really think about it, yeah, that could be evidence-based, but when you really think about it, how can I speak such change and tell somebody to commit to this drug or this treatment, not really knowing and understanding their story, at least a little bit of their context? So what frustrated me in residency was that I would see a patient in the hospital and then know that whatever I did, sure, I helped them get better there, but when they left the hospital, they went back to their lives where it didn't matter what I said, what I recommended, they went back to their lives. And I didn't understand their lives, and I wasn't trained about understanding their lives. So that was the second thing. The third thing was kind of this meta moment that I had some months ago, where I realized that none of this is new. This information is not new, certainly not new to God. This is the story of brokenness, wrapped up in epidemiology in a science-driven format. But this is not new. And communities, especially marginalized communities in Chicago and elsewhere in the country, in the world, have been telling us this for as long as time, So that's the caveat that I want to say here is that, yeah, we label we're labeling people's struggle as ACEs, we label the response as trauma-informed care, and now that's garnering all this attention, and we have to kind of step back and say, none of this is new. And it's kind of ridiculous that now we're starting to pay attention because we have these fancy terms to it. So that's an indictment on me, and I want to say that. But this is not new. As we go through today, there are three sort of self-reflection questions that I'd like you to ask yourself. The first one is, what has surprised you? The second one is, what's inspiring you? And then the third thing is, what has touched your heart? What has moved you today? And so at the end of today, we'll kind of circle back to these questions and give you a chance to speak to these questions. Now, was anybody not here at the church when I spoke back in June? One person, 2, 3, 4. Okay. So I'm going to tell this story again because I think it frames very importantly this topic of ACEs. So in the 1980s, there was a physician named Dr. Vincent Lee. He was working out at a Kaiser clinic in San Diego, California. And he, at the time, was running a weight loss clinic, really successful. The intervention was like a Slim Fast-like supplement for the patients, and fasting, alternating with fasting. And so a lot of people, men and women, were losing weight very quickly and keeping it off. But then over a period of 5 years, what bewildered him was that he had a dropout percent of 50%. And it wasn't because people were failing. Most of the people who were dropping out actually were losing weight or at goal weight at the time of dropping out. So it really bothered him, it confused him. Why would a patient leave our program if it's working? So he interviewed as many of these people as he could. He found about 280 of these participants. And it was through one woman's story that he kind of ran into. He accidentally stumbled upon this really bizarre phenomenon. So the story is, while in the program, this woman went from 400 pounds, over 400 pounds, down to 130. And then she disappeared for a few months. She left the clinic unexpectedly. And when she came back 3 or 4 months later, she had regained about 40 pounds. And when he asked her what happened, she told him that after she had lost all this weight and gotten to about 130, she was at work, and an older coworker hit on her. He asked her out, sexually propositioned her. And that solicitation, that unexpected, unwanted solicitation, brought back all these memories of when she was repeatedly sexually abused by her grandfather when she was a child. And it was actually that moment in her youth when she began eating increasing amounts of food daily. So when this older gentleman asked that propositioned her, it brought back all those feelings. And it turned out, through their conversation, he found out that for this woman, eating and gaining weight was actually her way of protecting herself from other potential predators and threats. It was a defense mechanism. It was what she could do to defend her space. So one quote that came out of their conversation was, "Overweight is overlooked, and that's the way I need to be." So Dr. Fellini took that interview and said, he told us that we need to ask everybody about their history of childhood trauma, especially sexual abuse. Came to find that well over 50% of both men and women who left the program had a history of sexual abuse in their youth. And so the big aha moment for him and his team was that what was perceived as the problem, right? You can blame it on me. What I see as the problem in clinic, when I see a person who struggles with weight, being overweight or obese, I say, you got to change your diet, you got to exercise more, you got to eat more healthy foods. That to me is the problem. So what we saw as the problem, obesity, poor diet, sedentary lifestyle, was in fact for these patients, their solution just to a different problem that happened much earlier. So this is a big aha moment, and what led to kind of the formation of this concept, adverse childhood experiences, or ACEs, which we call the hidden epidemic. We're just now starting to unpack. So with that, I want to just talk about three things in the next 45 minutes or so. What are ACEs? How do they link to mental, physical, behavioral health problems? How do ACEs cause problems? So that's important when you design interventions. And then what do we do? What can we do, especially in a church context, in a faith context, what can we do about this? So our story picks back up. Dr. Fellini was in San Diego. He went to the CDC, said, I need help, I need to study this. I think we kind of stumbled upon something really interesting. So he teamed up with a guy, Robert Anda, and together they formed the Adverse Childhood Experiences Study. This was a monumental, landmark public health study done in the late 90s. So it's not exactly new. It was done in the late 90s. It was a joint effort by the CDC and Kaiser. And what they did was they asked people in the Kaiser network about their history of childhood trauma, ACEs. So what are ACEs? Well, ACEs, as they studied it, were different types of childhood trauma that spanned three domains: abuse, neglect, and what they called household dysfunction, or disruption in the house. So within abuse, you have physical, emotional, sexual abuse. Neglect, there's physical and emotional neglect, and then the types of household disruption or dysfunction they studied were things like mental illness in the family member, substance abuse, alcohol, drugs in a family member, history of domestic violence against the mother, a relative who has been incarcerated, and then parental separation, abandonment, or divorce. So these were the 10 ACEs that they studied. Okay. Now, in terms of the study design, I won't show you. I'll skip over a lot of the nitty gritty. In case you're interested, then I'll slow down and walk through it. But I just want to point out here that they had 17,000 adults. This is a humongous public health study. And so a large sample size in which they were able to design a very nice study where the exposure was ACEs. So they asked patients about their history of childhood trauma, and then they also asked them about their history of current chronic disease, mental health problems, behavioral problems, both through interviews and through medical records. And then they analyzed the information. Now, the demographics are really important to understand about this study, because stereotypically, when we think about communities who have endured a lot of trauma, When we think of communities who have struggled, we think, oh, it must be poor communities of color. Like those are the people who struggle, and that is true, absolutely. We know that from history. So, but the danger is to distance yourself and say, my friends, my family, my church, my work, we don't have those problems because I don't see it. People don't say anything. So this doesn't apply to me or my circle or my sphere of influence. And that couldn't be further from the truth, and this is why. So gender, they had slightly more women than men. In terms of the racial breakdown, 3/4 were white. The next highest, the largest minority group were Hispanics at 11%, then Asians, this is San Diego, and then African Americans. The average age was over 60. I think it was 64, if I'm not mistaken. So largely middle to older, more elderly population. And then over about 75% had some sort of college education. So by all accounts, this was a mostly Caucasian, middle class, middle-aged, educated participant group. And so there's no distancing ourselves from this. This is probably one of the most affluent participant groups I've ever studied in such a large scale. This is us. So what did they find? Well, I'm going to condense it into 3 things. And I talked a little bit about this when I came in June. The first thing they found, the story goes when Dr. Anda uncovered this first observation, he wept. Most of these 17,000 adults had ACEs. 64% had 1 or more ACEs. That means only 36% of these 17,000 adults, who are mostly Caucasian, mostly college educated, mostly middle class, grew up with a normal childhood. So here's sort of the breakdown. 12.5% had 4 or more, but again, only 36% had 0. Now the most common types of ACEs they found, the top 4, were physical abuse, substance abuse in the family, separation and divorce from parents, and then sexual abuse at 21%. So 1 in 5 had a history of sexual abuse. This is not a rare thing. This is surprisingly and shockingly more common than we think it is. So that's the first thing. ACEs are common, and they're common in affluent and non-affluent populations. The second thing they found was what we call a dose-response relationship. So the more ACEs a person had, the higher risk they would be for some of these health outcomes. So what does that mean? So they came up with what they called an ACE score. And that was how many of these a person had. So there's 10 of them, the denominator is 10. And if a person had none of them, their ACE score was 0. If they had all 10, their ACE score is 10. If they had 4 of these, their ACE score would be 4. What this didn't account for was the frequency. So a person could have been physically abused by 5 different people in their lives. That's still counted as 1. There's a limitation there. A person could have been a victim of sexual abuse repeatedly for years. That's still counted as 1 ACE. So there are some limitations with this ACE score. But even with those limitations, they found some very compelling findings. So here's what they looked at. They looked at the relationship between ACEs and different things, health risk behaviors like smoking, alcohol abuse, IV drug use like heroin or illicit drug use. They looked at mental health conditions, depression, anxiety, PTSD, suicide attempts, chronic disease, adult onset heart disease, COPD, which is an adult lung condition, cancer, diabetes, and then other things like disability, mortality, poor self-reported health. And so, just quickly, I want to show you what this looked like because it's, for people who are interested in epidemiology, this kind of gives you palpitation, this excites you, it does for me. But, so what we're seeing here, right, we're looking at ACEs and health risk behaviors. So that's on the x-axis, smoking, heavy drinking, and IV drug use, IVDU. And what you see for smoking, right, on the y-axis is the percent of that health problem. What you see here is that people with 4 or more ACEs have a history of smoking at a much higher frequency than people with 0 ACEs. Same thing with heavy drinking, same thing with IV drug use. Now if we go to mental health, we see the same stepwise or dose response kind of pattern. So the different colors represent the different ACE scoring. And what you can see with mood disorders, that's depression, oppositional defiant disorder, people with an ACE score of 4 or more have a much higher frequency of mood disorders than people with an ACE score of 0. And everything in between kind of steps up to that. So you know that's one of the epidemiological principles in the Hill criteria, that when you see a dose-response relationship like that, it suggests, it doesn't prove, but it suggests causality. Same thing with anxiety disorders, substance abuse. You see it? And impulse control, like ADHD. Attempted suicides, same kind of relationship with the ACE score at the bottom. Chronic disease, so ischemic heart disease, which is adult onset, so heart attacks, coronary artery disease, stroke, COPD especially, and diabetes, all have a similar, although less well-defined relationship to ACEs. And then ACEs with worker performance, so absenteeism, financial problems, and job problems all show the same relationship, where people with more ACEs have more of these problems compared to people with less number of ACEs. Now this is just prevalence data. This is not telling us about risk. And if we think about risk, the next set of slides here show the risk of an outcome in these circles or behavior with the corresponding ACE score in the top left. And so don't worry about reading what they say, just look at the size of the circles. So here's baseline, people with an ACE score of 0, an ACE score of 1, 2, 3. To the extent where for people with an ACE score of 4 or more, or an outcome like suicide attempts in green here, people with an ACE score of 4 or more have an odds ratio of 1,200% greater risk of having a history of suicide attempts compared to people with an ACE score of 0. For alcoholism, 7 times. So I've listed the outcomes here, right? We're looking at odds ratios now, which is a measure of risk, and I've just listed it in order of magnitude. This is jarring, right? What we're saying here is that for a person with an ACE score of 4 or more, they have almost a 5 times greater likelihood of having a history of using drugs than a person with an ACE score of 0. For severe obesity, 1.6 times. Physical inactivity, 1.3. For chronic disease outcomes, this is, for me, this is when my jaw was on the floor, because what are we talking about here? We're not talking about smoking as a risk factor. We're not talking about cholesterol as a risk factor. We're talking about childhood trauma as the exposure here. Something that happened years ago is showing up as a risk factor in causing problems in adults years later. So for COPD, this is that adult lung condition. It's kind of similar to asthma in the way it appears as far as symptoms. A person with an ACE score of 4 or more has almost a 4 times greater likelihood of having a history of COPD compared to a person with an ACE score of 0. Now, to give you some, I talked about this back in June, just to put this into perspective. Okay, Stan, you're talking about numbers here. I've never seen these numbers. Why do I care? What does this mean? Let me tell you what public health does. Right? This may help to put these numbers into perspective. For something like secondhand smoke and lung cancer, we know that there have been a lot of policies that Chicago and various communities in the suburbs have enacted to limit a person's exposure to secondhand smoke. Because why? Secondhand smoke increases a person's risk for lung cancer. When you look at that number, right, in a similar type of study with a similar type of number of odds ratios, that number is 1.3. So a person who is exposed to secondhand smoke has a 30% greater risk of having lung cancer compared to somebody who's not exposed to secondhand smoke. If I show you early smoking by ACE score, we can see that a person with an ACE score of 2 and higher already has a higher risk of early smoking, which is the ultimate risk factor for lung cancer. But okay, Stan, you're not talking about the same thing, right? One is talking about exposure to smoke, the other one is talking about actually smoking. Well, we can compare actually apples to apples here by looking at the outcome of lung cancer. So what we see here is that a person with an ACE score of 2 or more has a higher risk of getting lung cancer than a person who's chronically exposed to secondhand smoke. And yet, public health, we jump around, we get excited, we get angry about secondhand smoke, gotta cut it out, and I say that's great, right? We should limit secondhand smoke. That is a great public health intervention. However, what are we doing about ACEs? What are we doing about childhood trauma? If an ACE score of 2, only 2, can confer a higher risk for lung cancer than secondhand smoke.
And that's because they started smoking earlier?
This one is actually controlled for smoking. Right? That's a great question, though. All right, so there's a dose-response relationship. Now, the third thing they found, and this is shocking, but it's no surprise, right, is that ACEs are associated with early mortality. If ACEs are related to all these problems that we just talked about in a dose-dependent way, we should see, it's not surprising then that people would die earlier than people without ACEs, right? And so this is what we found. So in the 90s, they formed this cohort of 17,000 people, and they followed them forward 10 years, and they looked at all the people who had 6 or more ACEs, all the people who had 0 ACEs, and they looked at, okay, what's the average age they are when they pass away. So someone with an ACE score of 0 lived to about 80 years, whereas someone with an ACE score of 6 or more, their life expectancy dropped to 60. The difference of 20 years, again, and this is controlled for age, sex, race, education. The difference being childhood trauma in America, in the same communities, all across, this is in San Diego, but we're generalizing it to the entire country. The difference being trauma confers a difference in life expectancy of 20 years. Now, when you've been in this space for a bit and you're staring at ACEs all day, you start to ask yourself, okay, are there more than 10 ACEs? Because I can certainly think of some examples today where there's other types of trauma that aren't listed here. And the answer is yes. And so this is sort of an analogy of how it all fits together. If we look at ACEs as like a tree, right, and the branches and the leaves of the tree represent our conventional ACEs, right? Abuse, neglect, household disruption. But every tree needs roots to grow from. So here, we consider the roots to be adverse community environments. Things like poverty, community violence, lack of educational and economic opportunities, racism and discrimination. But roots need soil to draw nutrients from. And so here, we consider the soil to be adverse collective historical experiences. Narrative historical experiences that have left a multi-generational impact. Things like slavery, things like what's happening in Syria today, the Holocaust, forced displacement. These events don't just impact one generation, they impact multiple generations. And so this is sort of one model of how it all fits together. Okay. For the sake of time, I'm gonna skip this part. It's really important. What I want to do is jump to how. And so we just talked about all this, I just showed you all this epidemiological data. Now we want to get to the really interesting stuff, right? How is this happening? What is happening to a person when they're exposed to child trauma and then they end up with all these poor health outcomes? So this is the big question that a lot of people have been asking in the last 20 to 30 years. And the short story is, ACEs cause what we call toxic stress on the brain, on the developing brain especially, and has downstream effects on our endocrine, our hormonal system, our immune system, our neurodevelopment, and then this thing called epigenetics, which I won't get into, but I think is really interesting. But it's thought that ACEs lead to toxic stress, and without the proper buffering and protective mechanisms in place, that toxic stress can then lead to the poor health outcomes that we see. So I'm going to focus here on this neurodevelopment piece, because this is A, I'm a pediatrician, B, this is where most of the evidence is, I believe, and the most solid. So Sigmund Freud, before he got into like his hypersexuality work, he actually was a really good psychologist. I mean, he was all throughout his life, but he saw a lot of patients, and he had a deep interest in understanding psychosis. And so after seeing one patient, he declared very profound, very in an insightful way, I think this man is suffering from memories. And so how right he was as we understand this science today. So let me back up, right? Stress. We've always had stress. Humans have always encountered stress. And, since we've been on this earth, in a lot of ways, our survival, especially in the pre-industrial era, our survival has depended on how well we responded to stressors and how well our body could kick into high gear. What I mean by that is when you see something frightening like a bear, right? You need your body to kick in so you can get out of there, so you don't get eaten by the bear, or stay really. You need your body to respond accordingly when you encounter a physical threat. So what happens when you see a bear? Well, your sympathetic nervous system kicks into gear, right? And sympathetic doesn't mean that it's compassionate. It has nothing about it. That's not in reference to that. It's the type of nervous system that gets activated. When that happens, it releases all these stress hormones from your brain and your adrenal gland, things like cortisol, epinephrine, adrenaline, cytokines, and it's these hormones, these molecules that go to different parts of your body. So they go to your muscles, and they help shunt blood to your muscles so that I can run faster, run harder. They shunt blood to your eyes so that I can see the threats that are going on. They shunt blood away from my gut, because the last thing you want to do when you're running away from a bear is have to poop. So these are all good things that our bodies were designed to do very deliberately in response to a threat. But the problem is, what happens when there's a threat that keeps it on, and keeps it on, and keeps it on? What kind of long-term damage actually happens in the face of a persistently active sympathetic nervous system? Now, when we see a threat, universally, if we saw a bear, we'd experience this. But the output of our behavior may look very different, right? So this is where that saying fight or flight comes from. You may get mad and have the guts to fight the bear, or you may run, right? But in children, there's a third one. Does anybody want to guess what? Freeze. So children, especially when the abuse and the threat is coming from a loved one and someone who's supposed to care for them, and an adult caregiver, the most common response in children is freeze. When a child is being exposed, is being molested, by an adult caregiver, that adult caregiver is supposed to love and protect them, the child doesn't know where to go. Where do you run to? Who do you fight? I'm too small. So they freeze. And so this is one of the most common outputs of the sympathetic nervous system that we see. Now, there are different types of stress, right? We were talking about kind of extreme examples there, but there are positive types of stress, and I talked about this in June, right? So the positive type of stress, the first, before you start your first day of work at a new job, before your first day of school, before a big test. These are, you could argue in the moment they don't feel very good, they don't feel very positive, but they are positive in that they're formative. They help you accrue necessary skills and knowledge. They're resilience-building encounters, and that's a good kind of stress. We all need that stress. That kind of stress is good for us. We need to be challenged and overcome those challenges, right? But then you have tolerable types of stress, which is, by definition, a stressor that you don't want in your life, like a car accident with an injury, the death of a loved one. It's a discrete event. It happens, but with enough support and care around you, you can overcome that stressor. It doesn't leave a lasting effect on your life. There's a third type of stress, which we talked about earlier, toxic stress, right? Toxic stress, by definition, is severe, it is frequent, and it is prolonged. So think about that in terms of your sympathetic nervous system. You have a threat that activates your sympathetic nervous system to a very high magnitude, multiple times, over a long period of time. So that's what we're looking at here. Not these formative types of stress, not even the tolerable kinds of stress. We're looking at toxic stress. So what we know in early childhood development about the brain, one of the things we know is this, right? In the first 2, 3, 4 years of a child's life, there is a tremendous proliferation of their neuronal network in the brain. So on the left there, it's a very pixelated picture, but on the left there, you see that's sort of the neuronal network in the newborn brain, and by 2 years it looks like this, to the extent that some people say there's hundreds of trillions of neurons in the brain by the time a child's 3. Now, I have a toddler, and apparently his brain has this many, it's debatable, but he has something like this, right? And that's normal. That's normal childhood development. But we also know this. So one of the outcomes one of the measures of childhood development that we've looked at, we've studied, is language, vocabulary development in youth. And we know that at 36 months, there are very vast differences in children according to their parents' socioeconomic status. To the extent that children of college-educated parents know many more words than children of parents who are working class and receiving public aid. Do these parents love their children any less? No. So there's something else going on, and the answer is that's poverty. So what is poverty doing to the potential of children on a community level, community-wide level? Now, in the last 20 to 30 years, there's been a really amazing convergence of this science from neuroscience, neurobiology, early childhood development, psychology, all on kind of understanding what stress does to the brain. So this is what we call a PET scan, and it's looking at blood flow in the brain. And the way that this is oriented is if I'm lying on a table, my feet are towards you like this. And so the way that you interpret it is parts of the brain that are active will have more blood flow to them. A fundamental principle of brain development in early childhood is that neurons that fire together, they wire together. But so the flip side of that is neurons that do not wire together, that do not fire together, will not wire together. And so if they don't fire together, they don't wire together, you're not going to see blood flow in that area. So what you see on the left here is a child, a healthy brain. They're circling the temporal lobes, which is important for auditory and sensory processing, receiving information from the world and knowing what to do with it. And you see that the temporal lobes they're red, lots of blood supply. But in the abused brain, the same area, the same cut, much less active. So that's brain function. And brain architecture, brain structure, in extreme examples can be affected. So I showed this back in June, but on the left, this is a CT scan. On the left is a 3-year-old child who was raised in a normal, loving environment. The child on the right here, however, was raised under conditions of extreme neglect. And you can see the size difference here.
So their overall size plus the internal structure.
Right. So this is saying that so much function, there's been so much lack of neurons firing together that they don't grow. The brain has less of a scaffolding to grow into a normal size. Now, I will say that when you remove children from these environments, they resume brain growth, but it doesn't get back to normal as far as we know. But they can resume. This isn't the end of the story.
Isn't that a natural protective instinct that they don't feel certain things so that they won't get hurt?
Right. So that's kind of that freeze part, right? And that's a really important point to bring up, because when we're exposed to a stress, and when children are exposed to stressors, especially of this kind of magnitude, we don't just sit there and deal with it. We find ways to cope. We find ways to adapt. And the problem is when we choose, just like the example that I talked about in the beginning of the women in the weight loss clinic, the problem happens when we choose the coping mechanisms that work for us but hurt us at the same time. That's when we see problems that we're seeing through this data. Now, the brain, I just want to highlight this, because I think this is also important to kind of understand how things are organized in the brain. So the way this is a heuristic. This is not, if there was a neuroscience professor here, he would shoot me because he said, no, the brain, everything does everything. And that's true. This is a heuristic, kind of a working model of the way we understand how different parts of the brain function primarily. So the brain develops from the bottom up with our primitive brain, or the reptilian brain first, which controls our breathing, kind of the automatic function. Breathing, coughing, gag reflex, our heart rate that we don't ever think about, making sure our heart beats. Then this middle section is the emotional brain, which houses the amygdala, which is our center of fear and pleasure. And then you have the top there, our neocortex, the thinking brain. So now, in the emotional brain, there's a center called the amygdala. And the amygdala is what Bessel van der Kolk, a prominent psychiatrist at Harvard who studied he's done a lot of research in developmental trauma, what he calls the smoke center, the smoke detector center of our brain. So when you come across a threat, it's your amygdala that lights up and guides you to safety. So when you're driving down, what's the big highway, 94 here? When you're driving down 94, someone cuts you off, your amygdala kicks into high gear and guides you to safety. You either stop, swerve, or the threat isn't meaningful enough for you to change your action. The neocortex is the center of the thinking brain, executive function, planning for the future, self-control, empathy. And so when your amygdala is active, there's a negative feedback signal to the neocortex. Because what you don't want to happen, if you're driving down 94 and someone cuts you off, you don't want to say, oh, he cut me off. Let me think about this. Let me contemplate my options here. Like, he didn't mean that. You know, maybe I'll hit him gently. Like, you don't think about that. You don't need that part of your brain to be active. You need to get to safety. The problem is, when you have that kind of pattern from toxic stress in a critical period of a child's life, because neurons that fire together wire together, neurons that do not fire together, they do not wire together. And so if you have a child whose amygdala is persistently active because of toxic stress, that will lead to I don't want to say abnormal, but it will lead to an effect on the development on the frontal cortex, the neocortex of that child's brain. So here's the working model, right? Starting from birth to death, conceptions here, these are the factors that are already in place before a child is born, those active, adverse collective historical experiences, adverse community experiences. After the child is born, then we have ACEs, which lead to a disrupted neurodevelopment. And like you pointed out earlier, that disrupted neurodevelopment leads to coping skills, which we do naturally. We find ways to cope in the face of stress. And as Dr. Fellini once said, it's just hard to get enough of something that almost works. So the problem is when that coping mechanism is smoking cigarettes or drinking alcohol or using drugs or promiscuous behavior, all those things could be a way for people to cope. Now, do people without any ACEs still smoke, still drink, do these things? Yeah. But people with ACEs do these things at a much higher frequency than people without. Smoking cigarettes, nicotine is actually a really great but temporary, very transient antidepressant. And it's actually it's an anti-anxiety agent too. So if you know somebody who smokes cigarettes, they probably tend to be a very anxious person. And smoking calms that down. So smoking cigarettes actually helps ease their nerves. But there's collateral damage, as we know. I mean, there's lung cancer down the road. So it's not a good thing, but does this change how you understand people who smoke? You know, does this kind of change the way that you think about people who do these risks? Have you ever said, I don't know why they do that, they're only hurting themselves, I don't understand? Maybe you do now, because I certainly was in that group myself. And then, of course, these things lead to disease, disability, and early death. Now, if we think about health as an iceberg and our system addressing the things that are above the surface of the water and all the things underneath the water we don't see, and you overlay this pyramid on top of it, and this is what the system that I'm working in and day out does. We do these things really well. America has the best acute care in the world. Do we do good preventive care? No way. Do we invest in social services like other countries? No way. We are missing so much of what's happening underneath the water, and this is where I feel like, you know, organizations like GRIP, the church, this is where we step in. The health systems should change too. Okay, now the response, right? So we're about an hour mark in. There's good news, but a whole lot of work to be done. Now the question here is, we know that not everybody, you know, some of you in this room may have 3, 4, 5, 6 ACEs, but guess what? You were able to adapt. Not everybody with a high number of ACEs is doomed to failure or an unsuccessful or a maladaptive life. There are people who are still able to succeed despite that. So what is it about you or the people who are able to be successful despite high numbers of ACEs than people who don't? And so research has shown that one important factor that helps differentiate people who are successful, who can adapt, and who can't, who don't, is this idea of resilience. And so it's the ability to adapt in the face of significant adversity. So how do we cultivate, how do we build resilience? That's the next question. Because we know that resilience is what transforms potential toxic stress into tolerable stress, which with enough social and protective, loving support around you, does not confer downstream damage to your brain, to your body, etc. Now, one way to understand the development of resilience in children is to kind of visualize the seesaw, right? This is from Harvard. And protective experiences here on one side counterbalance the negative experiences on the other. And so resilience is evident when the scale tips towards the positive side as opposed to the negative side. So what are some positive factors? Having a strong, stable relationship with the caregiver. This is the ultimate game changer, that if everybody had, they would have a fighting chance to withstand these egregious events that they've endured in childhood. The second thing is having self-regulation skills. So this is more technical, this is more science, psychology driven, but it's the idea of kind of re-accessing those parts of the brain that have a hard time being active as a result of growing up in the context of trauma.
Stan, if there's like strong, stable relationship with the caregiver, isn't that a little bit contrary? Because one of the problems with the ACEs is potentially a poor caregiver. Are they able to form good bonds with the caregiver, given the history?
Yes. So from the abusive caregiver, no. But from a different caregiver, yeah. Right. And that is possible, and then we see that happening. And actually, that's how people survive, because a boy could have an abusive father, but have a loving mother, loving grandmother, loving relatives. And that boy is fine, right? And that may resonate with your own story, right? And then the third really important thing is having a connection with people in a community, especially in a faith context. The negative factors we already talked about, right? Poverty, abuse, bullying, absence of one or more caring adults. Now, the bottom line for building resilience, it really boils down to two things. The first one is that self-regulation piece. Exercises to sort of settle the amygdala, calm the amygdala, so that the frontal brain can awake and be active, right? That's not what we're talking about today. The second most important thing, or equally as important, is having meaningful, healthy social connections. So this includes interpersonal, and again, that faith community. And so that's why we're here today. That's why I'm so excited to be here today, because here you are, right? Now you know this. And now you know that, wow, to build resilience in a child and in each other, it takes this. Like, this is evidence-based. This is what we know to be true. So that brings us to this idea of trauma-informed care. And I'm sure maybe you've heard this on like NPR or somewhere, you've read it somewhere. It's a very popular term these days, but again, it's nothing new. I have a slide here that says it's really like grace with a science back. It's scientific grace, right? Because as people of God, we know that we should treat each other in a way that's not judgmental. Our organization should treat each other in a non-judgmental way. We know this to be true, yet we don't always do that, right? So trauma-informed care is sort of like a philosophical approach to when you understand trauma and the long-term effects of trauma. Okay, so it's a really important concept to understand. But it's this idea of radical accepting of each other. And the important mental pivot is shifting your line of questioning or thinking from what's wrong with you to what's happened to you. That's a really important pivot that has meant a lot for me as I see patients in clinic. I know it's meant a lot for a lot of teachers when they see students who are disruptive. It's meant a lot, I'm sure, for social workers who are counseling children with trauma all the time. This is a really important pivot to shift from what's wrong with you to what's happened to you, because ACEs are not the fault of the victim. And so that's part of the narrative that we have to change. It's not what's wrong with you, but what's happened to you. And this is what I like to call scientific grace. Okay, so the key principles in trauma-informed care, and I only put this up here because as a church, these are some things that you can think about. These apply to any organization, your work, other organizations you're a part of. The sort of key steps in order for your organization, your community to be trauma-informed. First one is building awareness and promoting safety. That's a really important piece, especially with people who've endured very, very significant and prolonged trauma in their lives. Safety is not something to be assumed. Safety has to be an active policy of an organization. And these are universal measures that you have to put in place so that you don't assume that, hey, like, I'm not going to assume that you don't have any trauma, but that's kind of the default position of institutions, at least in healthcare. Then prioritizing trustworthiness, being transparent from the leadership to the constituents, emphasizing client autonomy, which then collaboration and mutuality kind of naturally goes into that. For healthcare settings, integrating care, so not having doctors operate in a silo away from nurses and social workers, but really integrating care across lines, and then being aware and understanding of cultural, historical, and gender issues. But the bottom line for this and what it means for an organization to be trauma-informed is that this is sort of embedded in the infrastructure of the organization, relationships. It's about how can an organization prioritize relationships over policies, over punitive measures, over rules. How do you prioritize relationships over everything else? And so that's where the term restorative justice, I don't know if you've heard that term, but restorative justice is kind of this thing that's being tested out and done in schools, in Chicago, in various communities. And that also is a way to an approach to justice in a trauma-informed lens. Now, the 4 R's I think are really important. And this kind of relates to the previous slide, but I think this is another way to understand it. So the first thing is to realize what trauma does, what it is, and what kind of effect it can have on people. And that's what we just unpacked the last 45 minutes. Now you know, you've heard it. You heard it from the horse's mouth, what trauma is and what kind of effects it can have. The next step then is to recognize trauma in each other, to understand, not in a judgmental way, but to if if you work, let's just take your work for example. If you see a coworker who may have been triggered by something and they're exerting a behavior that's not really consistent with how they've been in the past, maybe that's not just them having a bad day, but maybe that's something, maybe that's them remembering, maybe that's the woman who was triggered by the older gentleman asking her out on a date or sexually propositioning her who left the program. So that step is to recognize trauma, its signs and symptoms. The third R is then to respond. And so there's individual things that we can do, or things that we can do on an individual level, on a community level, on an interpersonal level, organizational, and so forth. And then the fourth R is to actively avoid re-traumatization. And so this includes and involves sort of universal policies. And if you're interested in more about this, in learning more about this, I can talk with you after and sort of what steps you can take to make sure that your policies are in line with this, wherever you work or the church. Okay, so that leads me to this next segment. And I think we can do that. So Aria is going to pass out an ACE questionnaire. Okay, and this is optional. You do not have to do this at all. But if you want to, what's going to happen is she's going to pass out the questionnaire that was actually given to patients back in the 90s. Okay, and it's pretty intuitive how you fill it out. But what we want you to do, don't write your name on it. Don't show it to anybody unless you want to. But once you tally up your score, rip off a little piece of your paper there and write your score on there, and Aria will collect it. What we're going to do is just tally the average score of this group here. Okay, we're going to see, think about what you think the average is going to be, and then we'll think about, we'll discuss what it is. We'll tally it up, find the average, and then we'll have a time for discussion and questions after that. So I'll give you 5 minutes to fill that out.
So Stan, the toxic stress where the nerves don't develop, are they filtered down to more scientific, exactly what causes the nerves not to grow?
I think it's kind of that amygdala, frontal lobe feedback loop that we were talking about earlier, about how when this part of the brain is kind of hyperactive, there's downregulation on other parts of the brain. And if that happens, over and over again in a critical period of development, then neurons that don't fire together, they won't wire together.
So I was wondering if you know about with adults who has experienced this ACE, but who grew up in the 30s and 40s and 50s and into the 60s, and this happened to you with who are not able to function and who has to live off the system. And is there anything that can be done that way?
Yeah, so it's hard because in terms of reversing the effects of that trauma, it's harder to do that the older a person is. It's not, there's a thing called neuroplasticity, which we like to talk about too, about how neurons can actually respond and heal over time. But at the very least, for those people, you can be trauma informed. We can be understanding and more understanding of their experiences in the past. But in terms of what can be done to reverse what's been done, there's not as much information. All right, so if you have your score, please rip off a piece of paper and Aria will go around. Just write the score on there, not your name or anything.
Got a question for you. Number 6, your parents are ever separated in work?
Everybody else. So I ask you, like, did you know that about each other, right? We go to church together. Did we know this about each other in this church community? And does knowing this change maybe the way that we would kind of treat each other, or the way that we invest in this community? And I think that's kind of how we begin to take this head knowledge down, bring it down to the heart, right? Because I think it is pretty sobering, right? There's people here with, what, 5, 6, 7 people with 4 or more ACEs, one as high as 8. So it's a prevalent thing in our communities. What I want to do is maybe we can just divide up into two main groups. So these tables here can combine. And in these groups, and Ari and I will be kind of roaming around, but we're just going to let you talk. And these two questions can kind of prompt your discussion. So what's your reaction to learning of this group's average ACE score? How can you respond? And then how can the church respond? Okay, so we'll give you a good 15, 20 minutes to just talk with yourselves. And you don't have to talk about this, but just something to start from and inspired you. Is touched your heart. And yeah, I'll just open the floor to let anybody share on any of these questions you want.